Hello everybody, welcome to my YouTube channel Nurses Simplified. Today we will talk about one of the very critical topics, that is CVA and nursing management of patient with CVA. Before that, we will go into anatomy of the brain. This is just a small glimpse of how our brain and its main parts. So this area is your thalamus, this is your hippocampus, this area, and this area we call the cerebellum. This is your brain stem. Okay, I don't want you to look at each and every part, but just a few areas. Frontal lobe, and this is your corpus callosum, this area. Why? Because these areas, if the infarct is in any of these areas, involves any of these areas, that will lead to the loss of the function of that particular area. Now, this is very important to know, that is a circle of Willi. That is the basically, what do you mean by a circle of Willi? Circle of Willi, it is one of the main components or one of the main arteries, arterial supply to our brain. So, how does circle of Willi help us? It helps us to basically know that it provides and it gives a connection between the anterior and the posterior circulation. So it provides a collateral flow to the affected brain regions. When so if there is just like your cardiac, which artery is blocked, and you know that which area of the region is blocked. Similarly, if this is anterior communicating artery, there is a block here in case of an ischemic stroke, then you know which area is involved. This is your basilar artery, and this is your anterior cerebral artery, this is your posterior cerebral artery. So these areas are important, or these are the main communicating arteries through of the brain supply. Now, this is another very important part, that is your functional areas of the brain, which means that frontal lobe. When you see the infarctus in the frontal lobe, immediately you should know that the patient will have problem with the movement. I'll just highlight it for you. Immediately we will know that the patient has problem with the movement, or in problem solving, concentration, behavior, thinking, and so on. Now, if you see in the CT scan report, it is in the parietal lobe. So immediately it should come into your mind that parietal lobe means it will have problem with the language, with the perception, attention, and so on. And if you see that there is a arterial block in the brain stem, you will know that the patient will have problem with the breathing. So these are few areas which you should know when you are dealing with a CVA. What is the WHO definition of CVA? CVA WHO definition says that stroke or CVA, cerebrovascular accident, is a focal neurological deficit due to what? Due to a local disruption in the blood supply to the brain. If the neurological deficit exists for more than 24 hours, it is called stroke or CVA. If it is less than 24 hours, you will hear a term called TIA, or transient ischemic attack. So if you think about the definition, it is a sudden death of brain cells, just like your myocardial infarction. This is also like, but this is a brain. So this is a sudden death of your brain cells due to lack of oxygen, caused by what? A blockage of a blood flow, that is ischemic, or rupture of an artery, which is hemorrhagic to the brain. Now, the risk factors are like modifiable and non-modifiable, and you will find it very similar to the one that you see in the MI, or a cardiovascular disease. Modifiable is hypertension, heart disease, smoking, excessive alcohol consumption, obesity, sleep apnea, metabolic syndrome, sedentary lifestyle, and drug abuse. Non-modifiable, which we have no control, it is your age, gender, race, if you have a strong family history, and heredity. Causes. I have divided this into three. The first cause is called the cerebral thrombosis. That is, maybe there is an atheromatous plaque, so which will form in the artery that we discussed about the circle of Willi. In any of that artery, it will form a plaque. Now, what do you mean by a atheromatous plaque? Let us go into it. Atheromatous, or something that is related to atherosclerosis, is called atheromatous. So what do you mean by atheromatous? It is just nothing, an atherosclerotic plaque. So it forms in the artery of the brain. It leads to clot formation. Then that increases in size and it blocks the blood vessels that supplies the blood to the brain. Cerebral, now if what you have, if there's an embolism, it is a clot formed outside your brain, maybe in the neck or in the thorax. And that clot, it moves because of the blood flow. It moves and it lodges the blood vessel in the brain. Hemorrhage, on the other side, it is a wall of the cerebral vessel. It ruptures because of some contributing factors. That can be because of the wall has become thin enough, or it has become stenosed, whatever reason. So the wall of the cerebral vessel ruptures and the blood rushes to and fro into the brain, destroying the brain tissue. Types, based on the causes, we have types. That is, first is the ischemic. Very important is your ischemic and your hemorrhagic, mainly into two types. Under ischemic, we have embolic and thrombotic. What do you mean by embolic? As we just learned, that it is when there is an fat plaque or embolus, it breaks either from the neck or from the thorax. It breaks and it flows into the brain via our blood flow, and it blocks an artery there. Thrombotic is same thing almost, but here it will be a blood clot itself from the thrombus, which blood flow blocks the flow of blood in the brain. Hemorrhagic, on the contrary, it means at a break in the blood vessel. That is, your blood vessel has been broken, and because of that break, or what we call more commonly in a medical term, we call it a rupture, that has ruptured, and that leads and that flows into one of the blood vessels, I mean into one of the areas, leading to hemorrhage. It can be intracerebral, that is inside, or it can be subarachnoid. Now, on the basis of whether it is a ischemic stroke or a hemorrhagic stroke, I have classified, or I have brought down this pathophysiology. If it is an ischemic stroke, you will see a thrombus or emboli. There must be an embolus or a thrombus. That leads to reduced blood flow, depriving the brain cells of the oxygen and glucose demand. And because the glucose is not happening, so there is a depletion of the ATPase. So what do you mean by an ATPase? What do you mean by an ATP? You will hear this common thing in medical science, that is ATP. ATP is nothing but adenosine triphosphate. It is a sort of metabolism, and it refers to a process by which the cells produce and recycle the energy to the cell. That it is the powerhouse of the cell. So it basically ATP is the power of the cellular activity. So that starts getting depleted or coming down, and that disrupts the normal ion gradients. Free radicals are produced as a byproduct of cellular damage, contributing to the tissue injury. These immune cells are activated, releasing the inflammatory mediators that can exacerbate the brain damage, leading to infarction or irreversible cell death in the core area of the stroke, whichever. It can be frontal, it can be parietal, it can be the brainstem, wherever. Now we come to what can be the hemorrhagic pathophysiology. What is the reason? There is a blood vessel in the brain which ruptures, and that causes bleeding into the brain tissue. Now, this hematoma will displace and damage the surrounding brain tissue because that area has been occupied by this hematoma. Body's inflammatory response to the bleeding can cause swelling in the surrounding area, and this blood clot can compress the surrounding brain tissue, leading to increased ICP or intracranial pressure. Hemorrhagic strokes can lead to secondary injuries and neuronal damage and dysfunction. So, what are we going to discuss is about the warning signs of stroke. To spot the signs of a stroke, we have B fast. You will see it very commonly used. That is a B fast. B is for balance. The patient will tell you, I'm having loss of balance or coordination. Eyes, you will see the changes in vision. It can be ptosis, or patient is complaining of blurred vision. Face, drooping one side. Arms, there is weakness in one side of the arm, numbness or weakness of the arm or legs, whichever. Speech, patient is having slurred speech, or he cannot converse well as he was doing before. T is just time. Call immediately for emergency service, whichever is available in your country. As we told you before, that sign and symptoms you will see depending upon which area of the brain has been injured. So if it is a frontal lobe, you will see the patient is talking about paralysis and is unable to focus on a task, behavioral. If it is parietal, you will see patient cannot distinguish between left and right. Awareness not very clear. Eye-hand coordination is not correct. Occipital will be totally on vision. Temporal will be mostly with speech and memory. Cerebellum will be with the balance. You will see patient cannot coordinate the movements while walking. Brainstem will be mainly with breathing. Now, a more elaborative sign and symptoms. So, this is very good for the students who are preparing for their exams. Always, as I always tell you, even before, stress on writing the sign and symptoms system wise, always, because that gains you more marks. Because I, as an examiner, will love to see something that is organized rather than do 1, 2, 3, 4 and try to search for marks. If it is system wise and you have given me 7 systems or 6 system sign and symptoms, and if the marks are 6, I will give you 6 out of 6. Of course they have to be relevant, you cannot just talk anything, but it has to be relevant. Rather than someone who has written all the sign and symptoms, I will rather give them 4 or 4.5 because it is not organized. So this is how you organize. First is neurological system, because it is CVA. So we will stress on the neurological first. Hemiparesis, hemiplegia, hemianesthesia, or aphasia. Aphasia you have, that is, you cannot talk or you cannot express. That is what we mean by aphasia. And aphasia is a very common symptom in um, stroke. Like, it affects the ability to communicate. Okay, now depending upon what this whole thing called aphasia, it is divided into two. That is Broca's aphasia and Wernicke's aphasia. Broca's aphasia is called expressive difficulty. That a patient, he cannot produce a language. Um, he can comprehend, but he cannot tell you that it is apple. Okay, so that is called Broca's aphasia, and it is basically, you will find mainly you will find it in patients with CVA. There is, the speech output is not immediate. He cannot immediately take out a speech output. When you now next we have something called the Wernicke's aphasia. Now, when we talk about Wernicke's aphasia, we will talk about receptive difficulty. What do you mean by receptive difficulty? Which means that like, the sensory part, the fluent part is not very good with the patient, so language comprehension is not correct, but if the rhythm, grammar, everything will be okay. So these are the two types of difference. So Broca's is about language production and Wernicke's is about language comprehension. Next is dysarthria, altered level of consciousness. You may have seizures if it is a hemorrhagic stroke because of abnormal electrical activity, because that particular area have been deprived of supply. Next is cognitive impairment, emotional stability, instability. Next, we come to musculoskeletal. You might find spasticity or flaccidity of limbs, muscle weakness, difficulty in walking, ataxia. And what do you mean by ataxia? Ataxia, you will hear too much in psychology, but you will hear here also. It is a neurological sign where there is no where there is lack of voluntary coordination of muscle movements. So the patient walking gait will not be normal. Next, we come to difficulty in walking, as I told you, contractures, shoulder subluxation, that is a flaccid upper limb, and cardiovascular is hypertension or hypotension. You may have irregular pulse, you may have some cardiology, cardiac reason behind. Cranial nerve involved. Now, for example, seventh cranial nerve is involved with facial droop. Ninth and 10th cranial nerve will be involved with a dysphagia. Tongue and there's like slow movement of the tongue and this tongue deviation, that also will be involved when there is some cranial nerve is involved. So when we talk about cranial nerve, we have the 12 cranial nerves. Depending on that, we will see that the areas are also involved. Like for example, if it is a tongue deviation, what we know that it is hypoglossal nerve is involved. So cranial nerve, the number will be 12. So it is related to neurology again. Now, if we come to nystagmus, nystagmus will be related to your eighth cranial nerve. Why? Because nystagmus is nystagmus will be related to your eighth cranial nerve. So you will see that the patient will be talking about difficulties with the eye or a slow eye movement. involved with that cranial nerve. That is the eighth cranial nerve. Okay, and not only eighth, it can be also oculomotor, that is your third or your fourth or your sixth. So I'm just giving an example, but it can be any of them. Respiratory, irregular breathing pattern, brainstem movement involvement, brainstem involvement, decreased cough reflex, and that is why you will have a risk of aspiration. Respiratory distress if your brainstem is involved. Gastrointestinal is dysphagia, constipation, and incontinence because of lack of mobility, and sometimes even because of the medications. So, something that you want to know is that if patient is talking about right-sided weakness, your concentration should be that the left hemisphere is involved. If patient is talking about left-sided weakness, then you must be in your mind that the right hemisphere of the brain is involved. How do you diagnose? The most important is the history collection, physical examination, CT brain. These three things are the core components of diagnosis. You can go with cerebral angiography, lumbar puncture if it is a chronic meningitis. You may look for it. Lab investigations, you may also do. Medical management. Now we will come to something called the medical management. And when we talk about medical management, it is again divided upon the type of the treatment that we are doing. So our goal is to restore the perfusion, prevent complications. Immediate assessment should be utilize your diagnosis fast. Time is brain. So do not waste time. Just like your heart, your brain needs immediate reperfusion. So do not waste time. Medications, after you decide it is ischemic, you got your CT scan result, it is thrombotic or it is embolic or it is ischemic, you will start with your medication, that is TPA, tissue plasminogen activated. That alteplase, we call it alteplase in most of the countries, and it should be given within 4.5 hours of symptoms. So you will see your doctor asking you in the emergency, when did your symptoms start? Because that will decide my goal, whether he is a patient for alteplase or he is a patient for other code of management. Before giving alteplase, we always look for screening for bleeding. There's a questionnaire where you will ask about, like hemorrhoids. You will ask about any risk factors, whether you're taking aspirin and so on. Antiplatelet drugs. Aspirin is the drug of choice, clopidogrel. Statins, we give atorvastatin to lower the cholesterol and reduce a stroke to happen again. Control factors are your antihypertensive, diabetes control, and lifestyle changes. Now, if it is a hemorrhagic stroke, what is your goal? Again, you should discontinue anticoagulants if you are taking any. Control your high blood pressure. Generally they will give nicardipine in ICUs. You will realize, and we will give something called osmotic diuretics to reduce the brain swelling, and generally it is mannitol. Anticonvulsants, we give phenytoin as a drug of choice. And in hemorrhagic, always the goal treatment is surgical intervention, because you have to remove the hematoma or the reason or the aneurysm, whatever is the reason. Surgical management. Now, when we talk about surgical management, again here our goal is to restore reperfusion. If it's a hematoma or if it's a thrombus, I'm trying to remove it to start the reperfusion again. So, make your diagnosis very fast, then go for the treatment. Now, if it is ischemic, you will see something called a thrombectomy. The doctor will decide about thrombectomy. That is removal of a blood clot from the blocked artery in the brain. So this will bring the thrombus is removed, your brain is reperfused. Next is angioplasty and stenting. It is like a procedure in which a balloon is inflated within the narrowed artery, the stenosed artery, to widen it. Like it is a mesh tube that is placed in the inside the narrowed artery to keep it open. Cerebral bypass surgery, it involves rerouting your blood flow, the circle of Willi, around a narrowed or blocked artery to restore the adequate blood supply. Now what if it is a hemorrhagic stroke? Under hemorrhagic stroke, we have something called aneurysm clipping. What is that? Like a tiny clamp is placed at the aneurysm area to prevent it from rupturing or bleeding. And it is one of the very common procedures used in hemorrhagic stroke if it is due to an aneurysm. Now we have craniotomy, a very widely used procedure where there is severe bleeding. Craniotomy is performed where you open the skull. Craniotomy is, what is it? Opening your skull. And it is performed to access the brain and stops your bleeding. And after you open your brain, you will decide, is it clipping off, or you will do clipping, or you will do coiling, or whatever. Next common procedure is coiling, that is endovascular embolization. And what we are trying to do here is tiny coils we are placing inside that aneurysm through one catheter to block the blood flow, and the clotting will take place. Now, decompressive craniectomy. Now, what do you mean by decompressive craniectomy? It is when there is any brain swelling, a small part of that skull is taken to remove that pressure uh, on that brain. Okay, and very common procedure is called arteriovenous malformation surgical removal. That is when there is an AVM, that is an arteriovenous malformation. A tangle of it is like, your blood vessels are tangled together at an area. So what you will do, the surgeon will surgically remove it if it's accessible in that case. Nursing management. Now, nursing management is more comprehensive and very much asked in CVA. It is one of the very favorite questions. So, nursing management is immediate care and assessment. A rapid assessment must be done according to the National Institute of Health stroke scale to determine the stroke severity. Depending on that, you will decide. Next is your ABC, airway, breathing, circulation. Then is your vital signs, that is your heart rate, blood pressure, oxygen saturation. Neurological assessment, that is a level of consciousness, motor function, sensory perception, pupillary response. Your GCS will come here. Diagnostic criteria, immediately arrange the patient for a CT scan. And once it is determined if it is thrombotic, embolic or hemorrhagic, depending upon that you will decide. If the stroke is ischemic, patient will be ready for a TPA within that 4.5 hour of critical time. Next nursing management is preventing secondary injury. Now the injury has already happened. Now what you will see the patient is having increased ICP. So you will monitor for signs of increased ICP. That is another chapter in itself. We have something called Cushing's triad, which will help us to decide, or which helps us nurses to quickly identify that the patient is having increased ICP. So that we will discuss in a very quick in different chapter or in a different way. So we will not confuse this with this. That is so, but you will monitor for an increased ICP and implementing measures to reduce it. Next is aspiration prevention, assessing the swallowing ability. So you will keep the patient 30-degree up whenever you will feed, elevate the head of the bed, do not provide liquid, do not provide you will provide thickened liquids. Fall prevention, because patients do not have proper ability to mobilize and cannot identify the risk himself because of the cognitive disabilities. So you will have to implement fall precautions such as raising your bed rails, mobility and so on. Skin integrity, you have to think about preventing pressure ulcer because they have limited mobility. Next, very important is DVT prevention. That you will use compression stockings. You will continue with anticoagulation medication. And urinary and bowel management, you will always look after the urinary retention, constipation, because all this increases your ICP. Next is very important for that is rehabilitation. Rehabilitation is divided into four: physical therapy, occupation therapy, speech therapy, and psychological support. So physical therapy, you will aim is to encourage early mobilization. Occupation therapy, minimum ADL activities the patient should be able to do. Speech therapy, the patient must be able to overcome the Broca's aphasia or the Warnings aphasia by trying to communicate well, and also swallowing difficulties must be improved. Psychological support to the patient and to the family, because this is very depressive when your major ADL are involved. Now comes the very important part, that is your Nanda nursing diagnosis for CVA. First and foremost will be, I have divided into three: high priority, moderate priority, and next is low priority. But when you will write, you will not write like this. This is for your information. You will first start with ineffective cerebral tissue perfusion related to interrupted blood supply to the brain, evidenced by whatever clinical findings you get, subjective and objective data. Risk for aspiration related to impaired swallowing, dysphagia, evidenced by coughing while eating, drooling, choking. Imbalanced nutrition less than body requirements related to dysphagia. Risk for impaired skin integrity because of immobility and reduced sensation. Next is impaired physical mobility related to hemiparesis, unsteady gait, ataxia, and risk for fall. Self-care deficit, disturb sensory perception. I have also put something called low priority. This is like the psychological part of it, that is impaired verbal communication related to aphasia or slurred speech, and ineffective coping related to loss of independence. Next, they may in some question papers I have seen that they ask about patient education of a patient with stroke. So that basically it will be divided into stroke education, medication management, home safety, lifestyle modification, and community resources. All is given elaborately here. The risk factors about stroke you will inform. In medication management, you will talk about compliance. Home safety, you will talk about falls, you will talk about injuries and about pressure ulcers. Lifestyle modification like regular diet, exercise, smoking cessation, alcohol consumption reduction. Community resources, you will have to involve your support groups which is available. Thank you so much for your patient listening and understanding of CVA, and this is one of the very vital topics in GNM and BSc Nursing. Kindly focus on it. If you have any doubts, please comment below. Thank you so much. Bye bye. Do not forget to like, subscribe and share my channel. Bye bye.